Thanks. I'm impressed by the number of people in this room. It's quite unexpected and it's most welcome. So, de-escalation, risky or beneficial? I'd say both risky and beneficial. Since I'm really fond of skiing off-piste, I can say that what's beneficial can be also risky. So 4 parts to my talk. First off, antibiotic stewardship principles and safety of de-escalation. I'll present a randomized trial that's source of debate, and then we'll see in practice what we can do. So, antibiotic stewardship, as you've seen, the guidelines of the Surviving Sepsis campaign, AB save lives. If you administer them in a probabilistic way with that increase covering a broad spectrum from the first hour. Not a lot of data at that stage, since experts are not on duty 24/7. Well, as Patrick Timsik describes, very often we have a too broad a spectrum, but that's what the system pushes us to do. So all this leads to an overuse of broad-spectrum ABs, and of course all this promotes the emergence of multi-resistant drugs. Well, I mean, does this make sense? I mean, should we fight against this multi-drug resistance? As has been shown in several consecutive papers, I'm just showing the most recent literature here that's quite well crafted. The fact that in critical care medicine, multi-drug resistant increases the inappropriate use of ABs and indirectly the number of deaths by increasing an inappropriate AB therapy. So to administer broad spectrum ABs continuously without thinking, I mean, thinking it's good for the patient, it's like running fast into a brick wall. You end up by hitting it, and with these ABs that respond to everything eventually lead to a patient death. So to fight against this, there are several things to do. First off, hand washing, and when we see the developments over the past 15 years, it's in large part due to the introduction of hand washing, not just ABs. Of course, there's the quality of care, and first and foremost, clean hands, and of course, contact precaution, isolating infected patients, systematically isolating patients back from travel abroad because they're at risk, and of course, daily AB stewardship, and in that stewardship there's of course de-escalation. Well, de-escalation is very well summarized in this editorial by Matteo Bazzetti in Critical Care Medicine. What's it all about? Well, the goal is, of course, to reduce short and unnecessary AB exposure, reduce the spectrum of ABs on the basis of patient culture results, and the end goal is to reduce selection pressure and thereby the emergence of multi-resistant strains, and also, but that's most important, perhaps the cost. So this is something that's fully contained in the guidelines. De-escalation is grade 1B in the Surviving Sepsis campaign. Idea, of course, is a strong recommendation. So we need to de-escalate to streamline empirical microbial therapy. When we look at all the literature on de-escalation, well, we'll of course refer to experts on methodology, and it's at Cochrane that we find there's no adequate direct evidence as to whether de-escalation of antimicrobial agents is effective and safe for adults with sepsis, severe sepsis, and septic shock. So, overall, Cochrane, who's widely listened to, most of our practice is influenced by these meta studies and analyses that are normally followed religiously. Cochrane says there's not so much evidence that de-escalation is effective and safe. So the principle is take a broad spectrum treatment with cultures just before samples in the lab, cultures, get the results, and I de-escalate, move to a narrow spectrum depending on the culture results. That's the funnel principle shown here on the right. It's easy. Well, I find that not so easy in practice. I've listed here, but this is just by way of information. There may be others, not an exhaustive list, but there are at least 9 prerequisites for us to work. You need adequate diagnosis. Is there an infection? Perhaps we're not as good as the average, but we spend our day discussing whether or not there's an infection or not an infection in our patients. Are we going to treat the right infection site? Have we sampled the right infection site? If I listen to all my chest surgeons, I always ask whether the surgeons in the organ, always say sampling the lung. Have I done the right type of sample? Have I transported adequately? Was it not left on a mat for years? Was it put in the adequate culture setting? Do we have the adequate microbiological diagnosis in the lab? The right antibiogram? We feel that the doctors at the bedside don't have the right MIC for this. So do I correctly interpret the antibiogram? There are a few subtleties, and after that, have I made the right choice of ABs? I find these 9 prerequisites not that easy to put in place. And what's more, it's a concept that's very poorly defined. So the raft of publications say we've de-escalated, we're really good, we're really strong, it worked very well. Why don't we de-escalate more often? It's true that it seems to work well when we look at these observational and all pretty much retrospective studies. When we look at these studies, well, de-escalation is pretty vague because we de-escalate 30% cases, 64%, 31% relo. If we change the pathology, 42%. So this is something that a concept that the numbers can double from one team to another. These differences of practice or patient, we're not too sure. And when we look at the results, if we look, for example, at mortality, Saint-Etienne find that mortality is similar whether we de-escalate or not. There are some that find in the subgroup there's an increase in mortality. There's a trend, and some find there's reduced associated mortality. Ditto for severity scores. It's pretty much a mixed bag. It's normal. These are observational studies that are there to generate higher quality studies, so it's normal that there should be diverging results. Now, the study that I find the most informative amongst all these studies at South Korean, and which clearly analyze the situation. So they look at mortality of patients where they de-escalated, always comparing to a group retrospectively that hasn't been de-escalated. You see that de-escalation improves patient survival. So conceptually, this is something that I have difficulty in understanding initially, because we give effective AB therapy to our patients, there's no reason for it to change mortality. So what was relevant, they looked at what happened on the day of de-escalation, not the day of sepsis, but the day of de-escalation. And so what does it show? So we de-escalate 5 days, so quite late versus other studies. 5 days on, when we compare multivariate analysis on mortality, so page 2 on the severity score at on day 5, these are the determinants of mortality. And when we look at these patients, well, we see the group where they didn't de-escalate, those that have the highest page 2 scores, not the day that they were in AB therapy, not the admission day, but where the de-escalation's practiced. And also they had the highest CPI assist. So this study, I think, perfectly summarizes the situation. We de-escalate when the clinical situations improve, where the patient's better, where we de-escalate in a patient that's okay after 5.5 days of ABs. We can even wonder if we can't just even discontinue ABs. And then we come to studies such as this, a Spanish study, where if we just run through it, we see that de-escalations associated with a lower mortality in ICU. 90 days, so de-escalation protects, but only protects in that sense, in that we de-escalate in patients that are evolving favorably, so it's a marker of good evolution. When we try and look at this more rigorously, and we took patients with neutropenic patients, prospective but also observational study, and we worked with statisticians, rather complicated models that I don't have time to explain now on survival. Here we clearly showed that we de-escalate or not with logistic regression. Effect doesn't change patient mortality, doesn't impact on patient survival. That's a very reassuring message. You can de-escalate and there's no mortality risk. So this is an observational study in neutropenic patients. We chose these patients because they're probably the most fragile, the most exposed to this, and so it was a quite novel model. No difference in mortality, but an extension in the use of ABs in the group of patients that were de-escalated. So just bear this result in mind. De-escalation is part of AB stewardship. It reduced use of broad-spectrum ABs. It's sure we go from meropenem, vancomycin, an anti-fungic cephalosporin the next day. It's very efficacious based on microbiome results, so you need to have a very close partnership with a microbiome lab. It's a strong recommendation in all societies that recommend de-escalation, but low level of evidence. It's based on observational studies. So, is there a need for a randomized trial? Some are very much opposed to this. I don't know if he's with us, but anyway, maybe not. But we did one with our group, Azuria, where we tested very pragmatically. It's a very pragmatic study that wasn't done blind. We tested a group where we de-escalated versus continuation of probabilistic AB therapy, multi-center, non-blinded, randomized trial. 17 people who are used to conducting randomized trials and who used to dealing with infections. So we detected severe sepsis patients, sampled, prescribed empirical AB therapy. We had the identification of the bacteria. We received the antibiogram, and at that point we called a phone number that I had in my pocket, and at that point it was A or B, depending on table that was done on a Google Doc. A, we continued to the treatment that was initiated. B, we de-escalated. So the goal is, as we have in the commercial trials, is when the pharma labs come and sell you their drug, that's great. Non-inferiority of ICU stay, give or take 2 days. If it's extended by more than 2 days, that non-inferiority is not reached. So only patients with positive culture were included. In the group known as continuation group, which was with probabilistic AB aminozides and fluoroquinolone for 3 days, AB against MRSA, according to guidelines, so we continued beta-lactam broad spectrum. In the DS group, well, we discontinued everything. We de-escalated the broad spectrum beta-lactam, depending on the culture results, a discussion between the investigator and the person on the phone. We screened 624 patients. It's far more difficult, even if the study was done over a very short space of time. We de-escalated far less. We had far few patients than initially expected. The situation to be de-escalated. 120 patients included, 60 in one, 60 in the other, with a few exclusions. And the two groups, and here we weren't fortunate because the two groups were slightly imbalanced by age, for time between sepsis onset and inclusion, and with the infection side and the use of carbapenems was pretty much balanced favorably. The use of carbapenems was in the de-escalation group. Age, they were older in the continuation group, and the infection site, the lung, was more numerous in the de-escalation group. So it's more worrisome when all the factors are strictly non-significant. We know that there are a number of factors that can be significant every time we have 10 variables. And so the results, looking for non-inferiority, that is no more than 2 days difference between the two groups, we obtained a difference of 3.4 days in disfavor of de-escalation, with mean days 8 days, 9 in the DS group. When we do the analysis, we had a delta 3.4 days, a few variations in terms of mean duration too. So non-inferiority was not obtained, so the result's pretty complex to explain, because we can just say that we cannot claim that de-escalation is non-inferior to continued AB therapy. That's the only thing we can say. The only result is that we can't claim that with these data that de-escalation is non-inferior to continuation of initial AB therapy. In terms of survival, no difference even after adjustment. Kind of the various criteria that were significantly different with the two groups. In terms of readmission to ICU, no significant difference. 33% readmission in the DS group, 7% in the group where we continued AB therapy. In terms of organ difference, no difference. Mechanical ventilation, I mean, all this pretty reassuring. In terms of duration of AB therapy, here we had an increase in total duration of AB therapy during the stay in groups where we de-escalated. Not in the first episode, but on the stay when we took all antibiotic therapy until the patient was discharged. However, fewer broad-spectrum ABs in the de-escalation group. That needs to be borne in mind. What made the difference, in fact, was probably the number of superinfections that was more important in the all pathogen rather than these. Actually, what varied often in the second infection in the de-escalation group. So, non-inferiority was not claimed. So, mortality, similar. Organ failure, similar, more secondary infections in the de-escalation group. So this study has loads of limitations. Take a look at the paper by Timsit that shows what's limited. No blinding, and this may have impacted on the duration of AB therapy. Physicians knew what they were given. Difficult to have a blind in this type of study. Both groups were imbalanced by age and by infection site, and this probably had an impact. For example, if we just look at pneumonia, no difference, and non-inferiority obtained. In design, non-inferiority is questionable. We could have had a superiority design, but it would have needed far more patience. The ecological effect, which is the major benefit of de-escalation, was not well. We did screening, but we had fairly, we need far more patients to have an ecological effect, and at the time of the choice of de-escalation, there wasn't an ID specialist. We meet with the ID specialist to discuss this, but on a day-to-day basis, as soon as we change the AB therapy, we don't call in the ID specialist. That could possibly have an impact. The definition of de-escalation poses problem when you go from carbapenem to penicillin. I mean, it's really very simple. You move from cefepime to cefotaxime. We all agree that most people agree that we're de-escalating. Cefepime to tabobactam. When you go from fluoroquinolone to cephalosporin, well, it's not at all clear, and of course we tried with Emmanuel Vey and Jean-Ralph Zal, a whole group tried to consider the method, Delphi modified method, to offer a definition of de-escalation, and I hope this will provide some insight on the objectives to all this. We saw within the group that it wasn't easy for us all to agree. So in practice, what needs to be changed? A lot of observational studies say do it. There's one RCT that just says beware, caution. My own view is that you must never change our practice on the basis of a single study, whatever the field, and so we must continue to this. We must stop in ICU from changing all our practice as soon as a new study's out, even if it's our own. I think we need to continue to operate as we do. Avoid the marketing thing, you know, always do this, that, never do it. We have to look at the cost, the risk, the benefit individually, and that's why we're physicians. I mean, you have to do this analysis on a day-to-day basis. And what can work well is, of course, an approach such as this, by looking at clinical practice that gives us a lot of insights. This is what proposed by Marin Kolev. I'm glad that he switched to de-escalation, having spent a year with him, and it wasn't obvious that he was in favor of de-escalation. But when we look at whether patients improved, well, probably we can de-escalate if we have the conditions. But if clinically the patients worsened and we're not sure of the veracity of the sample made in the AB therapy, they probably need to reassess, maybe at the end of the analysis, de-escalate anyway, but we need to reassess the case. So in practice, to reduce selection pressure, lots of things you need to shorten treatment duration, avoid unnecessary treatments. We're giving wall-to-wall AB therapy. I mean, every time something happens, sepsis, we slap an AB therapy on it. We stop treatments every time there are negative cultures. Maybe biomarkers will help us. We need quality biomarkers in order to decide. And every time we adhere to the guidelines, in spite of the Tahaneket paper, we need to stick to the guidelines. That can help. And we've put out recent guidelines in the ICU paper. which gives you all the strategies for reducing the use of ABs in ICU, and this should become essential bedside reading for all the intensivists. So my message here is really a strong recommendation, remain strong. Probably we need to de-escalate. It's risky. I think it's risky for patients, but it's beneficial for the community, work for them as well. It's probably efficacious, needs to be demonstrated, not yet demonstrated in terms of ecology. Only one RCT that shows better use of ICU, but there's no real difference in terms of mortality. That's the take-home. Respect the guidelines, de-escalate, and of course caution, not systematic approach. Every time there's a clinical picture that doesn't encourage de-escalation, think twice before you do it. Thanks to all my co-investigators and their technical team. Thanks for listening. Thanks. I'm